Hey everybody, this is Dan Marsala, and this is my ECMO case study. So I actually had to um, go with a case study I had to find online. Switched careers, well not careers, but jobs, kind of at the very beginning of the semester. So yeah, so I had to utilize a online study for this one. So, case background. So, the patient was a 23-year-old male admitted for progressive dyspnea, increasing respiratory failure with suspected pneumonia. X-ray showed extensive bilateral shadowing in the lower lung fields. His initial gas, SpO2 75%, pH 748, PaCO2 38.5, PO2 41.9. The patient was administered cotrimoxazole, ciprofloxacin, doxycycline, and rifampicin, and with no clinical improvement. By day 5, radiological progression showed massive atelectasis of both lungs, a left-sided pneumothorax with mediastinal shift to the right side, and the patient was transferred to the ICU. So initial interventions was left pleural drainage, deep sedation with fentanyl, tramadol, midazolam, propofol. Mechanical ventilation is bilevel 32/14, pressure support 18, FiO2 50 to 80%. On those settings, the PaO2 improved to 94. Samples were taken from the bronchial tree for analysis, and treatment with Vanco and fluconazole was started. Viral, fungal, bacterial analysis did not reveal any infection factors, and echo showed a normal cardiac structure, dilated aorta, no valvular changes, left ventricular ejection fraction of 70%. So on the 10th day, the patient's condition suddenly deteriorated with chest x-rays showing expansion of inflammatory changes involving lower and middle lobes of the lungs. On the 13th day, percutaneous tracheotomy was performed, and the FiO2 was increased to 80 to 100%. The patient's creatinine and potassium levels elevated to 1.7 and 8.2, and renal replacement therapy was initiated with dialysis cannula inserted into the right subclavian vein, and continuous VV hemofiltration was commenced. On the 11th day, VV ECMO was commenced due to worsening respiratory failure and increasing organ hypoxia. A 15 French cannula was inserted into the right jugular vein, and a 20 French cannula was inserted into the right femoral vein using the Seldinger technique. Heparin was administered via continuous infusion of 2,000 to 2,800 units per hour to keep the ACT within range of 130 to 148 seconds. Initial ECMO settings was FiO2 of 100%, blood flow of 4 liters a minute, speed of centrifugal pump was 3,000 a minute, gas flow of 4 liters a minute, and ultimately the gas flow was set between 6 to 8 liters a minute. The ABG did improve to 735, PO2 of 108, PaCO2 of 54 on the first day of ECMO therapy. So over the next 2 days, the patient's creatinine and potassium levels normalized, and dialysis was discontinued. ECMO continued with a gas flow of 8 liters a minute and FiO2 of 100%. The vent settings was FiO2 of 50 to 60%, PEEP of 18 with a pressure support of 15. On the 23rd day, the patient's condition deteriorated again, and the x-ray showed bilateral pneumothorax, mediastinal emphysema, and left-sided hemothorax. The patient was treated with repeat thoracotomy and hematoma removal, and the heparin treatment was discontinued. Nitroparin was administered and subcutaneous injection. So they did an exam of the lung tissue, and it showed advanced interstitial and subpleural fibrosis. Signs of interstitial inflammatory process dominated by eosinophil granulocytes with bronchalization of distal airspace, and all microbiological tests were negative. The patient received packed red blood cells, platelet-rich plasma, fresh frozen plasma, and cryoprecipitate. Blood coagulation factor 7A was introduced but failed to reduce the bleeding. On the 34th day of care, the bleeding intensified in the pleural cavity at 5,500 milliliters a day, and it required surgical coagulation. Due to the inefficiency of anticoagulation therapy, increasing oxygenator clotting, the ECMO was discontinued after 22 days of duration. On the 68th day of admission, the bleeding stopped. 2 days later, the vent was discontinued and the trach was removed. And ultimately, after 96 days, 76 units of packed red blood cells, 9 units of platelets, 38 units of plasma, 32 units of cryoprecipitate, the patient was discharged home in general good condition. So here's some X-ray images of the progression of the disease. The first figure shows that extensive bilateral lower lobe shadowing. Figure 2 shows the atelectasis, and that which was bilateral, the left-sided pneumothorax, and as you can see, the right-sided mediastinal shift right here. The figure 3 was the left-sided hemothorax. And then figure 4, this X-ray was right before the patient was discharged home. And then figure 5 was 30 days after discharge when the patient had a follow-up clinical visit. And the case study source and image credit right here. And yeah, overall it was I found it to be a pretty interesting case study. Certainly seems like 96 days the patient went through the ringer pretty extensively. But yeah, that's it. Okay, I hope you enjoyed.